I appreciate the invitation to address this group. You have had so many excellent topics when I review the course that you've had since many months ago. And I know just finally we're getting around to death and dying, and you already had an introduction to that last time when Henry talked to you about advanced directives. Is that right? 2 weeks ago. Okay. So you've had a little smattering about death and dying, and it doesn't necessarily have to be as grim excuse me, and morbid as the weather is today. But it's not a topic that people are comfortable with completely. I remember about 15 years ago when we didn't talk about it, learn about this in medical school. We had no course in how to treat the dying patient. And about 15 years ago at the TMA meeting, there was a talk on death and dying. And we went in there, and there were only about 20 of us in this small room. It wasn't a popular topic. And the speaker said, well, there used to be 2 taboo topics, death and sex, and now only death remains. And so, yes, indeed, it seems that that's still somewhat of a taboo topic, although we're getting better about it. With Kubler-Ross coming and all the media out giving presentations on hospice and on the care of the dying, people are becoming more comfortable, but we still have a long way to go. And hopefully, in discussing our topic today, I can share with you some ideas concerning increasing personal comfort with dealing with this topic that will help each and every one of us in whatever work we do. Let me call your attention to the handouts. In the first article here is a classic article by Eric Cassell on the nature of suffering and the goals of medicine. Many of you have no doubt read this, which dates back from '82. It's just superbly done, and it will, as we discuss the dying patient and their caregivers, you'll see how this fits into this particular paper. And then a bibliography I put together in last year has a number of books in addressing this topic in different ways. There are classic textbooks on death and dying, and there is the Eastern approach, Eknath Iswaran, about the middle of the first page, Dialogue with Death. Excellent person. If any of you have not read Iswaran, he's well worth pursuing. His books are in the bookstores now. He writes very well on meditation, on the Eastern way of approaching death and dying, which is more open and more accepting than our Western action-oriented way of dealing with this topic. And of course, Viktor Frankl's Man's Search for Meaning, which Dr. Balfour Mount in Canada said was required reading for the human race. And indeed it is. Indeed it is. Man's Search for Meaning. But there are also some textbooks about the details of pain and symptom control, if you're interested in that. Number 2nd on the list, J. Andrew Billings, Outpatient Management of Advanced Cancer. It's really not outpatient. That's a bad title. It's Management of Advanced Cancer. And the beauty of this book is that it is exceedingly clinical, but it also touches on the psychosocial aspects, and it has some excellent chapters in how to break the bad news, which is very difficult for many of us. How to really approach breaking the bad news with the patient, with the family. Billings is another Johansson, the last one on the first page, The Physician's Handbook of Symptom Relief in Terminal Care. This is an excellent book out of California. Then Peter Kay, third one on the second page, Symptom Control in Hospice and Palliative Care. This book comes out of England, and you know England gave us a lot of compassionate views toward death and dying. Sorry. There's one more, and that is clinical, is Charles O'Shaughnessy. He's on page 3 of the bibliography. This book is entitled Hospice Medicine. So those 4 are books that you can look at if you're looking for details of pain and symptom control, which we certainly don't have time to attend to here this morning. The last page of the handout, I think, is so well done. La Maison Michel Sarrazin, and please pronounce, I can't pronounce French well, is really a hospice in Canada. And these principles are the principles that they adopted. I think that they are very useful when we look at dying patients and think about their care. And we include this page in the packet that we give to all new hospice patients and their families. And they find it very useful. So that briefly explains what we have here in the handout. Did you have a handout? I gave you one, Joan. So going now, time will pass much more quickly than we anticipate. Please feel free to interrupt at any time. If something I say requires clarification, or you'd like me to elaborate upon it further, this is your workshop, and I would like to help you in this endeavor. The whole point of a good approach to the dying person, whether it's hospice or whether it's simply tending to the dying patient's need in the hospital, the whole approach is to help the dying person conclude their life in a meaningful way. That's the focus. That encompasses many, many things. It encompasses, first of all, the fact that we must look at the person as a whole person, not only physically, but also emotionally, in the psychosocial aspects, interpersonal aspects, and spiritual aspects. And it doesn't do any good just to handle the pain and not address the conflict that's going on in that person's mind, or not address the family conflict that is surrounding him. So helping the dying person involves looking at the person as whole. As we look at the person in this way, three big issues come to mind, and I think we can group our care of the dying person and the loved ones surrounding the dying person in three categories that I sometimes call the 3 C's, because I just love to use the same letter of the alphabet for it helps me remember things. But a few years ago, when I was recalling what we did as a hospice team, what do I do as a doctor? What does the nurse do when she goes out? What does the social worker do? Our roles overlap. We have our own disciplines, but we overlap. And the 3 big things are, number 1, comfort. And we might comfort. And comfort doesn't mean running around with a bottle of morphine, but it does mean freedom from pain and other distressing symptoms. Number 1, unless you have a person who's free of pain, they cannot grow in the other areas of life. They can't accomplish the goals of living that they may still have. The second goal is, or the second area that we address, is communication. Communication, being able to share feelings with loved ones. If people die with everyone playing games around them, never meeting their eye, their dying is very unsatisfactory. They can die with anguish, with pain, feeling isolated, feeling rejected, if they have not been able to share those feelings with someone they love and trust. And number 3, completion. And completion is not just what Kubler-Ross says, finishing business, which is part of it, of course. But completion is making peace. And we'll address each one of these issues. Freedom from pain, able to share feelings with loved ones, and making peace. And those are the 3 big ways in which we help the dying person. Now, going to number 1, comfort. No person should want to die because of the pain they suffer. We have today excellent methods of controlling pain and permitting mental awareness. You don't have to knock a person out to control their pain. Dr. David Roy, who's a compassionate, philosophical ethicist, physician up in Canada says, if a person's time is bound to pain and distress, it can't be used for anything else. It can't be integrated into a unique expression of joy, hope, peace, promise, or forgiveness that would bind the person together and to someone else. And again he says, Dr. Roy is very eloquent, he says, the great efforts of palliative medicine and care really serve the deeper existential purpose of freeing a dying person's time so that there can be an awareness of the emotional and the spiritual changes that accompany dying. And that's what it's all about, to control pain in a way that still permits the individual to share feelings and to make peace, not to knock a person out. And thanks to Cecily Saunders, Robert Twycross, a number of people who have worked on this in the last 20 years, we can do that now. Now, there are a number of things. Pain and suffering are not identical, and Eric Cassell's article, I will refer you to that. We'll help clarify that further. But when people express pain, I'm hurt, I'm in pain, sometimes it is a cover-up for emotional and spiritual suffering. And in our Western action-oriented society, it is an acceptable way. Sometimes people feel they must keep a stiff upper lip. They must not express that they have pain. That just doesn't go. That's not the way it should be. And so they say, I hurt. And sometimes that hurt is certainly not physical, but can be emotional. There are different ways that people react to pain. Some people react to pain in feeling it to be the equivalent of still being alive. Now and then we have a patient who's non-compliant with their recommended pain regime. And when you get right down to the bottom of it, you'll see that as long as they feel pain, they feel alive. And they don't want to take anything to subdue that pain. And then there are other people that want to bear pain for various reasons. I had a 90-year-old lady who was a staunch New Englander and was in severe pain with a very painful knee. And I offered to give her something for it, and she said, but I don't care if I hurt. I'm perfectly willing to hurt. And that was that. That was her character, and she was willing to hurt, and she hurt. Then there is pain that can be seen as redemptive suffering. And offering up for the sins of mankind, expiation for one's sins. This is not masochistic. This is a laudable goal for some people who are oriented in this direction. But to carry it one step further, offering up sins for mankind, or offering up pain for mankind, is really part of world belief, and not only Christian belief as we look at Jesus Christ, but also the Dalai Lama, who was in this country a short time ago. He may still be here, I don't know. But the Dalai Lama, who heads the Tibetan philosophical world, and what the Dalai Lama said is suffering is not overcome by leaving pain behind, but suffering is overcome by bearing pain for others. Now that's a very profound statement. I'm still trying to get to the bottom of it. And it really doesn't fit in with our action-oriented way of me, my comfort first. This goes way beyond oneself, and I think it bears looking into. And of course, if you're music-oriented, all you have to do is listen to some of the great operas, and they will carry to you the concept of bearing pain for others. Wagner's Parsifal, for example, healing the wound by the sword that caused it, that smote him. These are great messages that we have all around us that help us expand our notions of pain and suffering so that we can include it in and not look at it simply as something that requires a pill or a shot to subdue. But we don't have a great deal of time here to look at details, and if you want more details, I've referred you to the 4 books, but please feel free also to raise your hand and ask. When we're looking at pain control, we have to remember two important principles. First, we must get optimum disease control. It does no good to sit there and hold a dying person's hand and say yes, you know, and love them and touch them if they're in pain. Obviously, they're not aware of the comfort that surrounds them. So first of all, getting control of pain is good clinical medicine. It's not soft medicine. It's attending to this disease and getting control of it in the best way that one can. And then it includes a competent clinical assessment and evaluation. It's not a soft option. Hospice medicine, palliative medicine is good, competent clinical medicine. Now, there are ways that we subdue pain with drugs, and there are other methods, non-drug approaches, and they're both useful, and they're often used together. We can't go into detail, but some of the non-drug measures are surgery, of course, debulking big tumors, X-ray therapy, magnificent for controlling the spread of cancer to the bone, one of our great modalities. And we often have patients that come on hospice and say, oh, I don't want X-ray, I don't want chemotherapy, I've given all that up. And yet, if it's pointed out to them that X-ray can be used very successfully in the control of their tumor in their back, they will accept it, and we will get good pain control. Nerve blocks and neurosurgical procedures, physical measures, physical therapy, supports, braces. One of the great modalities, the non-drug modalities, is massage. People will respond to massage. Massage is also a great way of nonverbal communication. We had a patient we didn't have him. I heard about this patient in California, a mother who was dying and a son who had been very angry at his mother. And communication, verbal communication was impossible between them. But he came every day, and in order to effect a resolution in his feelings toward her, he would sit there and massage her feet. And it helped the patient, it certainly helped the son in expressing the love he had for his mother. It was the only way he could express it at that time. So all kinds of things. Meditation is useful. Biofeedback. Relaxation techniques are very good. Hypnosis and acupuncture. I have not used either one, but I know they've been successful in certain hands in dying patients. And then, of course, prayer and diversion, laughter. Norman Cousins tells us about that in his books. Laughter is an excellent device for handling pain. And transcending the pain, and I alluded to that when I gave you this statement of the Dalai Lama. There are ways to transcend pain. It's difficult for the way we are oriented in the West to understand that, and that's why I allude to the Eastern approach, which helps us focus on that. But looking at analgesic drug therapy, there are a number of different medicines that we give depending upon the level of pain. Some people require nothing more than an aspirin, but most people who are dying of cancer, from 60 to 80%, do have severe pain, and much of that pain does require the use of narcotics. We can now use narcotics safely, without addiction, without respiratory depression, without causing tolerance, and when they are given around the clock and given properly, these medicines control pain very well and permit mental awareness. And we have reached the point now where 90% of severe pain in the dying person can be handled by the use of narcotics by mouth. Not by injection, but by mouth. That's very important, because if the dying person chooses to go home, as many do under the hospice program, the family can administer these meds at home. 90%. You don't need an injection. You don't need fancy methods, but although they are useful for a very small percentage. But somehow, many physicians still have the idea that in order for something to be powerful and effective, it must be given by injection. We were taught years ago that morphine was not, first of all, it was a very powerful drug and you stayed away from it. But we were also taught that it was not effective when given by mouth. And yes, it is destroyed in the body. but its bioavailability in the body after it goes through the metabolic process is from 35 to 75%. So all it is that you have to use 3 times as much as you do if you inject it. And once they understood that now, we use morphine very successfully. Morphine is the drug of choice by the World Health Organization for the control of severe cancer pain. And the aim of the World Health Organization is to make this drug available to countries in which it is not present right now, and they've succeeded very well. Yes?
You use the sustained release?
Yes, we do. Yes. Morphine has a half-life of 3 to 4 hours. And when they first started using it, we used it around the clock, every 3 to 4 hours. And the aim of using a drug in this way, whether it's morphine or Dilaudid, is to prevent pain from coming on. You know yourself, when you have a severe headache, if you don't take something right away, just about you can take anything and it won't subdue that headache. But if you take a couple aspirin immediately, you may be able to relieve that pain. So the whole idea is to give medicines to prevent the onset of pain. Now, fortunately, a few years ago, morphine was developed in a sustained release form. Morphine now will last 12 hours in the body. There are 2 forms. Roxanol SR will last 8 hours. MS-Contin will last 12 hours. And most everybody is using the MS-Contin, and there have been all kinds of things about the fact that the system of MS-Contin is better somehow than the other system. I don't know, the drug companies have big fights about that. But
what about the dosage of morphine that you use in a 40-year-old cancer patient versus an 80-year-old cancer patient? Is there a difference?
it may be the same, Ruth. It might be the same. Generally, I start in an 80-year-old patient, I will start with a lower dose because of the metabolic process that you all have heard about, that elderly people do not metabolize drugs as well as younger people. However, it depends on the severity of the pain, too. If you have a 80-year-old in severe pain, I'll start with 10 milligrams every 4 hours and go on. Going back to your question once more, the method of starting it varies with the individual. Some physicians may want to start with the controlled release BID. Every 12 hours give the MS-Contin. What works better for me is to give this every 4 hours in its immediate release form, and then when I have achieved a good level of control, I switch over to the sustained release. And that seems to work better for me. And again, going back to what Ruth said, the metabolic process, interesting is that we also use methadone. Methadone, it has a long half-life, may go up to 72 hours, which means that in the elderly person, it is cumulative. And if you give methadone every 4 or every 6 hours, pretty soon you'll have a patient who's over-sedated. It is not a good drug to use in geriatric use. It's excellent for children who are fast metabolizers. So there are differences in the drugs we use. Dilaudid has a half-life just a little bit shorter than morphine, and also can be used very successfully. Demerol is a bad drug to use for chronic pain of any kind, not just cancer pain, because it has a short half-life of 1 to 2 hours. You cannot increase the dose enough to give relief without causing a lot of psychotomimetic effects. Confusion, sometimes hallucinations, sometimes even seizures. It's okay for short procedures, but to give it chronically around the clock for the control of pain, it is not good. And most people do develop side effects, and it has a ceiling dose. You really can't go over 300 milligrams every 4 hours. Whereas with morphine, you could give a person 1,000 milligrams every 4 hours, working up to it, of course. Morphine has no ceiling dose. Dilaudid has no ceiling dose. You can give as much as is needed to control. And you'd be surprised at the mental awareness that still exists, even in individuals who get tremendous doses of morphine. It is a safe drug to use. Does not cause respiratory depression when it is given for the control of severe pain. The pain itself is an antidote to the respiratory depressant effects of morphine. And when titrated carefully, obviously you don't start out with a dose like that. So Might mention too that morphine can be used successfully not just for severe pain but also for general discomfort. For example, in a patient with ALS, Lou Gehrig's disease, and the patient's not really having pain, but they're very uncomfortable. They can't swallow anymore. They're obviously paralyzed, and for their general discomfort, give a low dose of morphine. It is merciful, and it makes that patient's quality of life so much better. Now, regular administration around the clock, said that. The route of administration, oral is the best way. There are other methods. It can be given into the spine. It can be given rectally, subdurally. It can be given into the subcutaneous space. And now we have such a thing as a patch. It's not morphine, but fentanyl. Have any of you used the fentanyl patch, or you heard about it? We're just starting to use it. The patch will last 3 days, and it comes in varying strengths. And they have not found morphine simply does not penetrate the skin barrier, so they're using a substance called fentanyl, which is a synthetic opioid. Pardon? F-E-N, fentanyl. F-E-N-T-A-Y-L. Is that right? Yeah, I think it is. Anyway, its trade name is called Geriatric. The patch is called Geriatric, and it's just now out. And I can see this being great, especially in children who don't like. Children will take drugs by mouth very well, but they hate needles, they hate suppositories, and so Geriatric or fentanyl is something that is coming. Now, there are all kinds of side effects of this that I don't think we go into, other than the fact that whenever you give an opioid, you have to start a laxative at the same time, because it absolutely stops peristalsis. And any of you who have taken Tylenol with codeine for a toothache, you know that's true. So that is one thing. Unless a patient has diarrhea, we must use a laxative when you use any opioid. Now, lest you think that all pain is responsive to morphine, we've learned, since the initial enthusiasm about morphine a few years ago, that there is plenty of pain that is not responsive to morphine. And we can't go into the details here. One of them is the pain of brain tumor. That is only slightly responsive to the narcotics, but it is very responsive to steroids and to non-steroidal anti-inflammatory agents such as Motrin. And so in those cases, you use a package of drugs. Also, in bone pain, don't use the opioid by itself. Don't use the morphine by itself. You have to use either aspirin or Motrin or steroid with it, or, of course, one of the best things is X-ray therapy. We have the worst pain is a neuropathic kind of pain, nerve injury pain, and a branch of that is the peripheral neuropathy that we see so much, particularly in AIDS patients, that has been very difficult to control. And they're recently using a cardiac antiarrhythmic drug called mexiletine, or Mexitil, and the cardiologists get real scared when we propose this, but it really, when you're using it for the control of peripheral neuropathy, it does not have any cardiac action. Mexitil is the trade name mexiletine, and we use about 200 to 400 milligrams a day. It's been very useful for peripheral neuropathy, for reflex sympathetic dystrophy, those pains that are very difficult to control with the ordinary analgesics. All kinds of things, but the time marches on, so we really need to get into the second C. Any questions?
Tegretol for nerve pain, that's only a minor...
Which one?
Tegretol.
Tegretol, excellent.
But I mean, compared to this is far superior for that product?
Well, sometimes you want to use both. I think I'd start, you have a neuropathic type of pain, and certainly start with an anticonvulsant and an antidepressant. Antidepressants are also useful. Nerve injury pain requires a package of drugs. And the three that we used the most were, of course, an opioid, but we'd also use the anticonvulsant and antidepressant, sometimes a steroid. That's still what we would go to first. If you don't get anywhere with that, try the mexilatine. And you can, I have given it together with Tegretol. I've also given it without, and I can't see too much difference. You know, I just hate to overload the patient with drugs. By the time you get through, you have a patient that's getting 4 more drugs, and that...
Also, can I ask you, this is not a dying patient, but the elderly patient who is just miserable with severe arthritis that does not respond to the non-steroidals. You don't want to give narcotics like codeine. How do you handle that? Antidepressants and...
Well, if the antidepressants work, it's a try. Trying various non-steroidals, of course, and you've probably already done that. Recently, Kathy Foley at Sloan Kettering in New York has been using low-dose morphine in non-cancer pain and in patients who are not terminally ill. I've only seen one study on it, and they've used it successfully. Low-dose morphine, they don't hesitate to use it, like 5 milligrams every 6 hours or something like that.
I've read some of that literature.
Yes.
I have a cadre of non-resident chronic pain patients that I'm treating with opiates.
Are you? How do you find it?
Well, we originally derived the concept by what you're talking about. If people have malignancy and they're going to die, nobody hesitates to relieve their pain.
That's right. And the others were just...
but they have chronic pain that's frequently manifested by a lot of anger, and it turns people off. And we thought, well, why couldn't you put them on scheduled opiates? It's a relatively small percentage of chronic pain patients, actually. And over about the last 8 years, through an arrangement with the chief of staff and pharmacy, I've been allowed to prescribe scheduled opiates over a longer period of time than is usually acceptable.
That's good. Will you publish your results? I'd like to see them.
I suppose I could. It'd be more anecdotal than scientific.
Well, I think that would be useful because people stay away from, you know, if not terminally ill, you don't get anything. And that's not right, because pain is pain. And you've probably been impressed with the safety and of the drugs and the lack of addiction.
Also, the lack of addiction is really the thing that's most impressive. I have every reason to believe that these people are taking them on a scheduled basis, not seeking outside sources. And they claim that it's the only thing that relieves their pain, makes it more.
What do you use the most?
Dilaudid.
Dilaudid?
Yeah. I have been using more of the sustained release morphine patients. And I have one veteran who was a bilateral leg amputee by way of a landmine, and his preferred opiate was paradigm, Demerol, and it just seems to work better for him.
Is all right?
Yeah.
How much do you use of
50 milligrams.
50?
No, 100 milligrams 3 times a day.
And that works okay.
It works.
Yeah. Well, glad to know that. Glad to know that. But
I do use a lot of antidepressants. Usually in a smaller dose than one you use for a major depression.
Oh, we appreciate your sharing that with us. I think that's very useful because, you know, up until Kathy Foley started doing this, I think the door was shut on that sort of approach.
I copied some of those papers and disseminated them around the hospital. People frequently look at you awry when you're doing that. It's not what you're supposed to be doing in medicine, you know, because the conclusion is that you're addicting people.
Well,
it's not really addiction.
It's good there are people like you who break new ground and help a better, more compassionate approach to the whole problem of pain. And I think that's very interesting. I'd like to know more about it. I'll come to you and get some more information. Any other questions on
Do you find that you have to use lactulose as the only laxative, or can they use something like Circa, something milder?
Yeah, I use a lot of Metamucil as
Metamucil
Yeah.
works too?
Yeah, Metamucil, lactulose, Senecot S, whatever. I've preferred a peristaltic agent. Sometimes Metamucil, without any peristaltic action, I've occasionally run into trouble with it. But there are a variety of laxatives that can be used. I don't think any one of them is the best. And so sometimes it's trial and error for all of them. Well, going into our second C, any questions on our drug or non-drug approach?
Do you ever realize, I know sometimes with pain control, it's been effective to have the patient control.
I can't hear you well.
Sometimes it's been effective to have the patient control their administration of the drug.
Right.
And actually use less of the medication.
Yes, patient-controlled analgesia we do use when the patient is alert enough to be able to push that button. But occasionally a person dying can rapidly go into a condition where they can no longer do that. Then you find the caregiver over there pushing the button. But of course most of it can be converted to a continuous method. Yes, I think that's very good. I think a PCA is good. It's probably not as good as it is in post-operative use, when we use it for the dying patient, but it is useful. It's very useful. Any other questions on this? Such a big topic. Incidentally, if you have a patient that requires a large amount of analgesic to control the pain, and you have unacceptable drowsiness and confusion and lethargy, I found it useful to give a little dexedrine with it. To give like 5 milligrams in the morning, 2.5 at lunch, or 2.5 both times, depends. Very useful, and you still have good pain control, and yet your patient is able to overcome that lethargy and the cognitive doldrums that they sometimes get when your morphine dosage is, morphine milligrams are up pretty high. So that's a good thing. Your patients probably don't require that, but when a patient is getting a pretty good dose, then that helps. And it's a nice adjunct. It's smooth. It helps the drug work better, it seems. Okay, on to the second C of communication. Next to pain, the greatest source of distress for the dying patient is failure of communication. And when there is miscommunication, it can lead to anger and mistrust and resentment and feelings of isolation and rejection and, of course, failure to attend to important business. When a person is dying, this may, of course, be the last opportunity to attend to things that are important for the individual as well as the family. And if people don't communicate readily, if they're all playing games, this never gets attended to. So caregivers who are taking proper care of the dying, who are aware of that, can help patients share their feelings comfortably. In a hospice setting, both dying patients and caregivers are helped to share their feelings. It is not at all unusual for the hospice to come in and find that, don't tell mother she has cancer. And still today, people are not being told. Usually doctors are much better about telling patients now, but occasionally patients don't hear, don't want to hear, and families want to reject that. So in their effort to protect the dying person, they will tell us that we don't want her to know she has cancer. Then we go to mother, and she says, I know I'm dying, but my children can't take it. Don't talk to my children about it. So here they are. They all know what the score is, and they need a catalyst. They need someone to help them communicate. And they will often ask a member of the hospice team to do that. It's not always the social worker or the pastoral counselor either. It can be any of us. It can be the physician, the nurse, the aide. They volunteer. They often help people. They say, will you help me? And this is one of the one of the goals of hospice is to assist dying patients and their caregivers in communicating fully and readily. Now, shared awareness of the true situation helps everybody involved deal with guilt and relieves their guilt, their fears, and their anguish. And the fear and the anguish of death can perhaps be most successfully eased by sharing those last few precious moments with somebody else, really in an open fashion.